All right. Hello. Thank you for tuning in. I am still Jessica, the world's most productive nurse practitioner, and this is office hours where I'm kind of talking about some issues that we encounter as nurse practitioners, as clinicians in the clinical setting. All this stuff that isn't really about disease process. It's not about pathophysiology. It's not about really caring for the patient. It's really more about caring for us. That is all the stuff that they don't teach us in school. I don't really care where you went to school. I don't care if you're an NP, a PA, a physician, a chiropractor, dentist, you name it, veterinarian. I've talked with veterinarians about this as well. So even people who care for animals, same sort of thing. The turning the lens on ourselves, taking care of ourselves, um, that's kind of up to us. And we figure that out on our own or not, for better or for worse. And what ends up happening, unfortunately, and I hope this isn't the case for you, is that we develop these not great coping mechanisms, things that will either get us through. So, sort of like putting a band aid on it, right? Kind of like just sort of not really getting to the root cause of the patient, sort of the same thing for us. So these coping mechanisms that'll get us through the day, get us through the week, get us through the year. Um, but really, we're just getting through. We're not thriving. We are not doing the best work that we could do. We are not doing the best for ourselves. And that spills over into so many aspects of our lives. It doesn't magically end at 5 p.m. It follows us. Even if you take a lot of time off, it follows you into vacation, follows you into your weekend, into your relationship. So I'm probably preaching to the choir. If you, if this resonates with you, drop a comment. But we don't learn these things. These are not part of the curriculum. And I'm not even here really to be critical about that because, again, no matter what you've studied or where you've studied it or to what degree you have studied, right? Whether you have a 2-year degree or a 4-year degree plus a 6-year residency and a fellowship and all that, you've learned a lot, right? The clinical knowledge that you have is substantial, and to pack that into whatever size container, whatever shape container that it got packed into is no easy feat, right? So if we were to then layer on top of that how to be your best self, how to live your best professional life, as we're kind of also learning these really fine detail things about how to take care of other people, it would be hard to do that. It would be really hard to strike that balance. I think it would be great if we could, but there are only so many hours in a day. There's only so many days in a week. So to be able to learn both of those things simultaneously, I don't know how we could do that, right? So the thing is, we don't. And then we get out there and we get into practice and we say, "Holy shit, I don't know how to do this," right? Like I don't know how to take care of myself. Like the taking care of the patients, like I kind of know, I know enough to get started and I know where to go for backup and for resources. But for the me part of it, how to not be charting all night and all weekend, how to turn off the clinical mind, right? And then live your life that has nothing to do with your time in clinic. That's hard. That's hard to do. It's hard to learn. And what I have seen for myself, but also for colleagues and for other people that I've worked with as coaching clients, that sort of thing, is it tends to be trial and error, right? You learn to avoid what not to do. And so you just don't do those things, but you don't necessarily know. It's like landmines, right? You're walking across a field and you know there's some pitfalls in here, but you don't have any real way of knowing until maybe it's too late, until something goes wrong. So I am personally, as the world's most productive nurse practitioner, I am on a mission to help with this, to do my part, to do what I can to make that less intense, to help people with that transition, right? From the student, the resident into practice and that role change that comes along with that, and to make the work world a better place to live because we spend a lot of our time there and a lot of our energy. So, as a part of that, right, I've got questions if here in office hours that have been sent to me. And I am going to dig into a couple of those questions and give my best Dear Abby style advice. And if that resonates with you, great. If it's helpful, that's the point. If you have questions, definitely drop a comment, send me a message. I read all my own emails. I don't have an assistant or anything. It's just me, maybe someday. But right now, it's just me. So everything that you send comes directly to me. I read it. I don't miss anything, right? Because that's how we're trained. So the first question that I have is about managing a visit with a difficult patient and basically how, right? And if you haven't had this happen yet, lucky you, but there are difficult patients out there. Absolutely. If you are a nurse practitioner and prior to becoming a nurse practitioner, maybe you worked at the bedside or maybe you worked in the emergency department, you have definitely experienced seeing patients, seeing people at their worst, at their lowest point, at their most uncomfortable. We're not at our best when we're sick, right? So we're not bringing our best selves to those encounters. So you've definitely had those experiences. But the difference is when you are working in a bedside situation, even if, kind of no matter what your role is, right? You're not the only person doing it. And you are there for your chunk of time, your 12 hours or whatever the case may be, and then you hand off, right? So it's a relay race. You're handing that off to the next person who's going to just kind of keep things going, ideally improving them. But the buck doesn't stop with you. The buck kind of doesn't stop until the patient is discharged one way or another. So you have your role to play, but it's really a team game. And you have other people that are there physically with you. Theoretically, they're stretched thin too. But there are other people that are present that, are sometimes coming in and interrupting, but that can also be there if things take some sort of turn for the worse, like a worst case scenario. But when you get into practice and you're working as an NP and you're working in that ambulatory outpatient setting and you're in that exam room and it's you and the patient, there's nobody else in there. Nobody else is going to come in there. The door is closed. Um, Nobody, generally we're not interrupted. That can vary, but generally we're not interrupted. So it's you and it's the patient. And if you have a difficult patient under those circumstances, you may also be seeing them at their lowest point, at one of the worst days in their life. The acuity is probably different than it is bedside, but not always. Sometimes it can be pretty intense. But sometimes it's not even a physical element that's making them difficult, right? It's not because they just broke their leg and they're in tremendous pain. Okay, that makes sense. But it's more of their composure or their lack of composure, in their affects and their attitude. And I've worked in primary care. Come on, of course, right? I've definitely taken care of plenty of patients like that. They are challenging. And it's implicit that being in healthcare and being the non-patient, right? So being the provider, being the nurse, being the tech, being the secretary, whatever your role is, but being not the patient, but somebody else in the healthcare ecosystem, that it's a customer service element. I see that. I get that. When I'm a patient, I expect some level of that, but I like to think I'm realistic. So we kind of get into that vibe, right? And a lot of nurse practitioners are female, and women are not socialized to say no. We are not socialized to be confrontational, constructively confrontational, not just like, pushing back for the sake of pushing back and start a fight. I'm not suggesting that. But I am suggesting, and I'm going to first point out that when you have this difficult patient who can take a few different forms. I have had the patients that come in, they make an appointment, they come in, they show up, they arrive, they jump through all the hoops, they let the person take their blood pressure, all this stuff, right? Then you get in the room and you ask them, like, hey, what brings you in? And they're just like not saying anything. Like, what is that? Why would you do that? Right. Or every answer is short, it's clipped, it's monosyllabic, right? They're like, there's not really this give and take. And in that setting, I'm expecting to have a conversation, right? So when that doesn't happen and there's no obvious reason for it, there's not a broken leg, there's not, it's not something that is obvious. I call it out. Right, nicely. I like to do it if I can with a smile on my face, but I call it out because we're not gonna do this dance. We're not gonna in the 10 or 20 minutes that we have together, we're not gonna play this game because that's not the best use of our time as far as I'm concerned, and ultimately, the buck is going to stop with me, right? If there's a diagnosis to be made, I'm making it. If there's a prescription to be prescribed, I'm prescribing it. If there's a referral to be made, I'm referring, right? So ultimately, the responsibility for this visit, it's close to 50-50, but it's not exactly 50-50. It's ultimately me. The buck stops with me. Um, so this is not the best use of our time, right? And there's something that brought them in, something that compelled them and motivated them to actually show up for the visit. And if this is the way that they're going to interact with me, there must be some kind of reason why. So I'm going to ask what that reason is. So when I've had the patient that is either giving me a lot of pushback or is not really engaging at all, I will ask them. I'll stop whatever I'm doing. So sometimes this has happened. I'm thinking of like one particular case. I was like listening to lung sounds. So I'm standing right next to the patient. We're pretty close proximity, and we're about halfway through the visit at this point. If I'm starting to do a physical exam, and just we're not getting anywhere, And if you're not going to answer my questions, it's going to be really hard for me to help you. So I said to the patient, "Have I done something to upset you?" And then pause and wait for the response, which is hard for me. I'm a talker, and I tend to talk a lot, and I tend to talk fast, and so it's hard for me to wait for that response, but it's so crucial in that moment. So to say to the patient, "Have I done something to upset you?" And sometimes they'll say, "No." Okay. And maybe that's true, I don't know. Like, I gotta take their word for it. But have I done something to upset you? Because you seem to be upset, and I don't think I did anything. If I did, I'm awful sorry. But it's a nice way of saying, we need to kinda have a back and forth. If I've upset you, like, let's identify it, and I'll do something, if I'm standing too close, if I'm talking too fast, if I'm rushing you, I can adjust, right? But if you don't tell me what might be upsetting you, then I really can't adjust. So to call that out, you can absolutely do that. It's okay. Ultimately, this is your visit. Even if don't feel that way, it is, right? You're the one who has to write the note afterwards. You're the one that if there's questions that's coming back to you, it is your visit. You are in charge. I believe in the co-production of care. I want to work with patients, but ultimately somebody needs to drive the bus, right? And so it is you as the provider. So it is okay to say to the patient, whatever version of this feels comfortable for you to say, have I done something to upset you? Or is there more to the story? Is there something else going on that I should know about? To put the responsibility onto the patients, even if it doesn't seem like they're like biting and they don't really give you much of a response, it doesn't seem to change things. You have at least, at a minimum, by having done that, you have advocated for yourself and you have shown one person in the world, if only that one, you have shown one other person in the world that you notice something that isn't right and you're calling attention to it. That's leadership, right? That is advocating for yourself. And who knows what may come of that? Ideally, I've had this happen as well. You say this to the patient. I didn't realize I had this. I got a ticket on the way here, or whatever the case may be. It's like something has nothing to do with you. They're holding on to that, and by you calling attention to it, it allows them to recognize what they might not have even recognized and release it and kind of shake it off, right? So that has absolutely happened as well. There have also been the times that I've called it out and nothing happens, nothing changes, and okay, we're going to keep this matter of fact, and we're going to just kind of truck through this visiting and get to the finish line. But in either case, you, by doing that, have shown leadership, you've shown advocacy, and you've shown role modeling. Because maybe this person, in other aspects of their life, we never know the influence that we're having on people. When people come into our office in a clinical setting, we expect to influence them as far as their health is concerned, right? Like that's kind of the transaction. But we don't know what kind of influence, good or bad, we might be having on people otherwise, right? Maybe this person has a lot of defense mechanisms and just hasn't ever seen somebody simply and kindly, but directly call something out. And maybe having that example will help them in other parts of their life to be able to do that for themselves. So there's a lot of good that can come out of this. It also helps because if you're always like trying to guess, if you've got a difficult patient and you're trying to guess what might be causing them to be difficult, you're probably not going to win. Like in the amount of time that you have with that patient, you're probably not going to guess it. You're probably not going to win the game show, and you're going to have spent all that time trying to do that when you could have just been direct. Now, some difficult patients will be very in your face about it, right? And they come in and they know what's wrong with them. They know what they need. They are irritated that they have to get it from you. Strange, right? Like you can't just buy antibiotics at the store. You have to get those from me, and you have to meet criteria in order for me to give them to you. So, but there are those difficult patients as well. And I don't have a lot of tolerance for that. No, I don't want to be unkind to them, but I want to let them know when they're being a little aggressive with me and there's some attitude. And in that case, I will call that out as well. So I've had patients that have come in and they're, very sure of what is wrong and what they need. And they'll tell me that sometimes, like directly at the beginning of the visit, which is efficient. So I appreciate that. And sometimes, I'll say, like, "Why do you think that? Where does that come from?" Um, we have to That's not how it works. Those are things that I say, and that they don't always wanna hear, but that's the truth. I'm being honest with you. I've also had patients who have come in and I've had, like, the chronic pain patients who then want to add, they're already on, hydrocodone, right? And they wanna add gabapentin. And, no. And no is the answer, and we have a lot of other options, but that is not the option at this time, and I'll tell them that, and, they're trying to really kinda sell me and pitch this change to their plan of care, and I can understand the logic, I don't agree with it, and they'll come at it from several different, angles, and the answer is still going to be no, it's not going to change my mind. I will have alternatives that are available, and we can talk about those and why those may or may not be the right fit or the right choice at this point. But gabapentin and hydrocodone at the same time today, no. And so I've had patients where that has happened, and then they get upset with me, and their attitude changes, and I will be very blunt and very direct in those cases. And I'm thinking of one patient in particular who wanted to change her plan of care in this way, and I did not. She was also not my patient. Interesting point. I was covering for somebody on like vacation, and so she was not even my patient. I just got her that day, and so she had suggested this, and I said no. I said that's not safe, and she said, well, all my friends do it. Okay, well, I'm not working with your friends, I don't think, and that's not safe. And then she pushed a little further, and I said, I'll be frank with you, I don't want you to die. I When we combine those two, there's significant risk for respiratory depression, central nervous system depression, and then I broke it down into the plainest language that I could use. I don't want you to stop breathing. I don't want you to stop breathing because then you will die, and I don't want that for you, and I really don't want that for me and my license. That's the reason. I mean, really, that's the reason. And the other reason is because there are a lot of other options in this patient's case that we had available to us. And so I wanted to talk about those options. She didn't. She ended up leaving, which, she did not like what she heard, and that is her right. She got up and left the visit. And so I actually had a few minutes of free time. So I finished up another chart. I mean, okay, right. I'm not going to fight it. So difficult patients come in a lot of different shapes and sizes. And the kind of keystone of what I use in terms of an approach is to just be direct, kindness as much as I can. That is harder sometimes than others because I am human, but to be direct with what I'm saying to them that, like, I'm not going to beat around the bush. You can't have those two meds together. Or I'm not going to beat around the bush. You've had symptoms of a sinus infection for 2 days, and antibiotics aren't going to happen today. Um, I'm going to tell you directly, and I'm going to give you other options, whatever other options that I might have available to give you within reason. I'm going to give you those instead. I'm going to call it out when I see it. Have I done something to upset you? And kind of put the ball back in their court, allow them to respond, and always keeping in mind the other nugget that goes along with this is therapeutic silence. Also hard for me if you can't tell. But if you've got that patient that is tricky, right, and that is maybe not as much of a talker, and so they're also stonewalling you is a little bit of overstatement. Excuse me, but they're being quiet with their responses, and that's coming across as, in a certain way, which may or may not be accurate. Um, Using that curiosity, using that directness, and then when I say my line that I like to use, which is, "Have I done something to upset you?" Um, then I am quiet, and in my head, I zip my lip, and in my head, I count to 10 slowly. Not 1, 2, 3, 4, 5, but 1, 2, 3. I count to 10, and that takes my power back. That helps me also to recenter myself, gives me a chance for, like, a deep breath or 2, right? And it also gives them that chance to reflect, respond. It doesn't always work, right? Like, there are just some fights you're not gonna win, but it does work more often than you might think, and it is a good tool to have in your pocket when these things happen, because there are pe everybody's this is it's these are wild times. It is a stressful world that we are living in, and it's just getting more stressful, every day. So you don't know what's going on in all corners of your patient's life, but when they're bringing this stuff to you, um, and it doesn't seem to be yours, and it doesn't seem to be warranted, be direct about it. Advocate for yourself, show leadership, and allow them this space to respond or not, and then proceed, right? And then you have to kind of navigate it from there and see what makes the most sense for you. But you have options. You don't have to just tolerate this. That's not right. And if somebody's threatening you, that's a different story, right? If somebody is physically or emotionally threatening you, that's security. Like, that ain't you. That's where you're calling it for backup. Whatever your security backup or your security protocols are in your clinic, that's when those get activated, because we do not tolerate threats. But if it's just, affect stuff, that you can call out, and you can allow for a little bit of space. We're counting to 10 in our heads. We're not giving it 5 minutes, but you can allow for a little bit of space for both sides to recenter, or to decide if they want to continue with the visit, because patients are in the driver's seat. They can leave anytime they like. Sometimes that I wouldn't advise that they leave, but they have choice, right? That's up to them. So I hope that these things are helpful. If you have additional questions, or you have stories that you'd like to share, or feedback that you'd like to give, then absolutely, uh, drop a comment, send me a message. Like I said, I read them all. But in the meantime, don't take any shit from people, right? You don't need to. That's not your job. Your job is to help them. And if you can't help them, it's your job to tell them that too. All right. Take care.